A meniscus tear is a common injury that affects the C-shaped cartilage structure within the knee joint known as menisc. The structure, the medial menisc on the inner side and the lateral menisc on the outer side, play a crucial role in supporting joint stability, load distributions, and shock absorption. Meniscus tear often result from a sudden twisting or rotating movement, particularly common in sport activities. Additionally, wear and tear over time, especially as we age, can contribute to the gradual breakdown. Athletes engaged in high-impact sport or those with occupations involving repetitive knee movement face an elevated risk of meniscus tear. The symptoms of a meniscus tear can vary but often include pain, swelling, stiffness, and sensations of the knee locking or catching. Some individuals may experience difficulty fully extending or bending the knee. The severity of symptoms can depend on the type and locations of the tear. Accurate diagnosis is crucial for effective treatment. Doctors may use imaging techniques such as MRI to visualize the tear and assess its characteristics. Physical examinations, including specific tests, evaluate range of motions and joint stability also aid in diagnosis. Meniscus tear can be characterized based on their pattern and severity. Common types include longitudinal, radial, bucket handle, and complex tear. The inner portions of the meniscus, especially in posterior horn of the medial meniscus, is often more susceptible to tear due to its proximity to the anterior cruciate ligament and increased stress during activities. Treatment approaches vary depending on the type, locations, and severity of the tear. Conservative measures may include rest, ice, compressions, and elevations, along with physical therapy to strengthening surrounding muscle. In case where conservative methods prove insufficient, surgical interventions, often through arthroscopic procedures, may be recommended. Surgical options include meniscectomy, removing the damaged part, meniscus repair, suturing the tear, or meniscus transplant, replacing the damaged menisc. Okay, now we can start with rehabilitation and return to sports after isolated meniscal repair. From biomechanical point of view, the menisc have a different function: load distribution, shock absorption, cartilage nutrition, stability, and the capacity of lower friction, increasing the congruency of the joint. The menisc have a high percentage of water content, giving the biomechanical function to resist compressions and axial loading. The menisc has two different orientations of the collagen fibers. The circumferential fibers predominantly convert and disperse axial and compressive loading, creating the so-called hoop stress effect. Differently, the radial one have an important function to counterattack longitudinal splitting forces of the circumferential collagen bundles, keeping the ultrastructure integrity. Lastly, it has been advised that the inner third of the menisc may play a major role in dealing with compression forces, while the outer two-thirds contract radial tension forces. In cases of vertical longitudinal tear scenario where the hoop tensile stress effect is preserved and the circumferential fibers are intact, a compressive forces at the repair site with loading could be safely treated with early post-operative weight bearing and unrestricted range of motion. Differently from that, a radial tear could be displaced with axial loading, dissolving the hoop stress effect, which may require a more conservative approach with non-weight-bearing post-operative strategy with restricted range of motion. Many authors support that the use of accelerated rehabilitation protocols with early weight-bearing and unrestricted range of motion after meniscal repair regardless of the tear parts. Becker evaluated meniscofemoral contact pressure while cycling the knee from extension to 90-degree of flexion after meniscal repair. The study demonstrated that even if the pressure increased in both compartments during flexion, the meniscal repair had no impact. Some authors recommended non-weight bearing and immobilization in full extension because during flexion, the peripheral posterior horn tears move away from the capsule but reduce in extension. Despite more aggressive protocols allowing for free range of motion and weight bearing as tolerated immediately after meniscal repair, the authors recommended a 90-degree of flexion as a comfortable restriction regardless of the type of the lesion. This recommendation is supported by Ahmed. The author demonstrated using a pressure distribution transducer for in vitro static measurement in synovial joint that up to 85% of the load advances through the meniscus with the knee in 90 degrees of flexion, while 50% of the load passes through the meniscus in extension. Following the concept of accelerated protocol based upon the TAS characteristics, Kakabe reported excellent results for different lesions. For longitudinal TAS less than 3 centimeters, they proposed weight bearing as tolerated without using a brace in association with a range of motion limited to 0 to 125 degrees up to the 6 weeks. However, for a lesion bigger than 3 centimeters, patients were wearing a protective locked brace with partial weight bearing with range of motion limited to 125 degrees until 8 weeks after the surgery. In the complex and radial test cases, wearing a brace with weight bearing as tolerated with range of motion limited to 90 degrees for 6 to 8 weeks were recommended.